perfect time and in a really global meeting which we are just now started. I just want to wish for everybody the success of this trial, and thank you the company for this kind invitation to be here once again. It's a great honor for me. I believe it's a great honor for our Ukrainian delegation because it may be one of the signs that this country just now returning to the market of clinical trials after maybe a short period of some problems, but I know now that many sites, many investigators are invited, and I absolutely believe that we all together will be successful in this very important clinical trial. So when I was proposed to deliver this presentation, I just discussed with my colleagues that it is really, you know, the topic, the question which have so many ideas to be discussed that it's rather difficult to be in time frames of our agenda. But nevertheless, I also believe and perfectly well know that we have over here the experienced auditor, and many questions which just now will be described, maybe they will be delivered with idea to maybe to remind you some basic principles which are, I am sure, absolutely well known for you. But when we discussed with TIWA, with our partners, the mood of this presentation, we paid attention that some questions which are really obvious, which are well known, should be refreshed, should be maybe some remind for the auditory will be done, and we believe that it may promote the success of our mutual activity. That's why, very shortly, I want to give you some maybe tips about well-known factors: the lung cancer mortality, widespread of these diseases, and after that, the modern approaches for the treatment of this disease and use of granulocyte colony stimulating factors, the G-CSFs, for the preventive and for the treatment of complication. The main of them is febrile neutropenia, which really negatively influence for result of the treatment. We will shortly touch the question about reduction of doses, about delays of doses in the process of treatment, and their influence for the final results of this treatment. We want also to pay attention for the modern guidelines which exist in this area, and the adherence for these guidelines, and to pay your special attention that we should improve something in this mode. And finally, the final goal of this presentation is once again to remind you this such modern approach which ensure the more safe and reliable patient treatment and better results of chemotherapy is really exist. Just now it is extremely important because the lung cancer, as you well know, now became the, maybe within the last 1-2 years, the most widespread pathology for the new clinical trials. Many of your colleagues will agree with me, I believe, that you will tell, we just now seems even overloaded with the new lung cancer proposition for clinical trials, because PD-L1 mutation and the immunotherapy, implementation of immunotherapy approaches for cancer, lung cancer treatment just now really changed the landscape of this pathology treatment. That's why, once again, I believe that our trial and our meeting is organized very in time, because we really will discuss important questions and very interesting approaches. So, of course, this slide, this picture shows that lung cancer is the most common cancer disease in the Europe. You know it, and the mortality in this disease really is very high. We know these figures. I will not comment it. The smoking patterns, you know about it. You know that male smoking is the widespread grown habit which we had many times, but now started from 1970s. this habit also influences the woman, and it is also influence for mortality rate. That is why increase of lung cancer mortality in women in most European countries reflect the increased smoking initiation in young women, as we just had mentioned. Well, so chemotherapy regimen associated with risk febrile neutropenia seems also to refresh and remind you these topics and this sentence. So you know that the surgery was and became the main mode of treatment for chemotherapy for non-small cell lung cancer for early stages of these diseases. But nevertheless, the percent of the patient which really may be operated and is not so high. You know that only 10 till 20%, in some statistics till 25% of the patient may be radically operated for the lung cancer. That's why, of course, some other approaches like radiotherapy, I mean stereotoxic ablative radiotherapy, it is also implemented for treatment of this patient, but also with the limited access. And the chemotherapy, the role of chemotherapy could not be overestimated. It is well known, and we just discussed this question. I mean that in the basic practice, the 4 cycles of platinum-based chemotherapy is the standard approach for treatment of this patient. You know, many comparative trials which try to answer the question, how long should this treatment be continued, how many courses of chemotherapy should be performed, and the answer is started from 4 till 6, sometimes 8. We know about the maintenance therapy, but in all the times, just now we may conclude that the patient with advanced non-small cell lung cancer complete 4 cycles of platinum-based chemotherapy, maintenance treatment may be considered maximum with 6 cycles. Well, so hematological toxicity. You know that one of the obstacles which we face in the process of this patient treatment is hematological toxicity. I'd like to say that based on my personal experience, the attention of physicians in the process of lung cancer treatment for hematological toxicity seems is a little bit lower in comparison with, let's say, breast cancer. Maybe I first thought that it was my own opinion, but when we discussed with Jiva, with the mode of this presentation, so I paid attention for many trials, many retrospective data, many meta-analyses, which prove the same, that it is related for, in general, for all medical humanity. That's why I believe it will be okay if I remind you that the definition of febrile neutropenia, that it is the cases when oral temperature is 38.5 or 2 consecutive readings of more than 38 degrees for 2 hours, or absolute count of ANC lower than 0.5. So, well-known factor, but we should, of course, remind it just now. So, over here you see the also known regimens of chemotherapy with high, intermediate, or medium, or lower risk of incidence of febrile neutropenia. Of course, the febrile neutropenia depends on the mode of treatment, chemotherapeutic agents, which we are using in our practice. So I will not comment, you see everything. So I just once again want to remind you that the references for all the slides are over here. I'm sorry, I will not mention the authors of these trials and references because of time efficacy, and will maybe point to show but not name the figures. You see it for yourself. And as my colleagues promised, that everything will be available at your stick memories, and you will more have possibility to see. That's why now I'd like to show once again some regimens the most often used for chemotherapy and the risk of febrile neutropenia which in reality exists. You see that these risks are very different, from very high till low risk, but it really exists and it should be taken into account. So maybe this slide decreases the simplest poor effect of febrile neutropenia appearance. I mean prolonged hospitalization. Of course it's important. Of course it is reflected that prevalence of serious neutropenic complication increase the growing burden of non-health care resources. So the medical system should pay more money to treat this patient. But I'd like to say, if we will not prevent this complication, if we will not influence for that in time, these expenses which increase dramatically. That's why very important sentence which should be taken into account. So lung cancer and incidence of febrile neutropenia. Very interesting study and very interesting observation you see over here, which calculated that in overall the 10.7% of the lung cancer patients in the process of treatment experience FN, febrile neutropenia, and for small cell lung cancer these figures are rather high in comparison with non-small cell, but since every 10, every 5th patients experience the episodes of this neutropenia. And what is also important, that most of these cases happened in the process of first cycle of the treatment. So it is maybe the indication for creation of our practice and the mode of our treatment of this patient, that we should be extremely attentive to this patient in the process of first course of chemotherapy, because it's like reflection what will happen with this patient next. So you see the name of this short presentation, effect of febrile neutropenia on treatment outcomes. Of course, we must know how it influences, and let's switch on, and which factors may contribute for the development of the febrile neutropenia in general. So, of course, the main, I don't know what is the main, everything is important. That's why these 3 columns, the 1, 2, 3, they reflect the demographic status of the patient. You see that age, female sex, performance status, nutrition, body surface area, they influence for the possibility to develop this complication. The second group of factors, it is of course intensity of chemotherapy, and other ones is laboratory test, the results which we preliminarily received prior to the start of chemotherapy, and of course the level of leukocytes, let's say neutrophils, started at the process of start of chemotherapy. It obligatory will influence for the results of the treatment. So all these factors may lead to the development of our complications or no. And the neutropenia finally may transfer to the febrile neutropenia or no, as we just mentioned. So what will be consequences of this event? What will be, what may happen in case of development of febrile neutropenia? So we know it is the complicated infections, it is bacteremia, it is prolonged hospitalization, and I believe that this case will not happen because we will be careful, we will fight with that, and many things will depend. will we in time switch on not only prophylaxis but the treatment of these complications? So this information, so it shows the symptoms, its signs which happened with this patient. May I please will not only to show and not comments, it is the general complication which may happen, pneumonia, of course, the infections in different sites, of course, the laboratory changes which are the markers, the indicators, are we successful in our treatment or no? So, since it's absolutely clear for this respected auditory. This slide show that febrile neutropenia, especially for the lung cancer, is maybe a serious factor, serious complication, which may lead to increased risk of death of our patient. So you see that it is associated with significant mortality, especially for the lung cancer. For all subjects, as you see, the figure is over here, the mortality rate in case of febrile neutropenia. But the lung cancer is one of pathological conditions. Over here, you see the percent of the risk of death in this patient is one of the most high, maybe only two other positions may higher risk. But lung cancer, let's say the most widespread cancer, with very high risk of this complication. So that's why we really accept with enthusiasm this proposition for this XM22 trial and that you selected lung cancer like the theme for this particular trial, because this figure proves that it is necessary, it is important, and it seems visible. So what else? Not only the risk of death, but the risk of lack of the results of our treatment. Because the results of our treatment greatly depend from the dose delays and dose reduction. And this trial particularly shown that the neutropenic events in 40% of patients after 21% of the cycle were accompanied with the dose delay, with dose reduction, with the need of extra additional hospitalizations and so on. That's why the results may be predictable more poor in this patient in case of development of these complications. So many slides, I should be not far from my computer, I'm sorry. So dose intensity effect on survival. You see that reduction of treatment duration lead to the reduced median survival time. So in this slide, I invite you to check and to read it in addition, because it shows that the number of cycles, the dose level, the dose density, cumulative dose are important factors for improving survival. And intensification of chemotherapy still deserves further research in small cell lung cancer. As I mentioned a few minutes before, the results in small cell lung cancer is even poorer than for non-small. That's why it is really important to pay attention for this part of lung cancer pathology. Well, so what we have just now, because we have the recommendation, we have the guidelines, they are not absolutely you know these ones. The first one is the RTC from 2010 guidelines, which separate our action to three different steps. The main is, the first step number one is to assess frequency of febrile neutropenia associated with planned chemotherapy regimen. We touched shortly the percent about that, and you see that in case of high risk, it is the prophylaxis G-CSFs must be administered immediately based on modern guidelines RTC. No need to do it in case of lower risk, it is not required. One in the middle risk, it's necessary to follow the next steps. We should access additional factors. One of them may positively, like for example young age, for example good laboratory test, good general condition, not so toxic chemotherapy. They may positively influence for the no need, for example, to administer this prophylaxis treatment. But in case when we have the old age of the patients, we have poor general status of this patient, lower results based on screening, so we should think about the start of this treatment and the next steps. And I just switch on another one. NCCN guidelines support CSFs prophylaxis for febrile neutropenia. Only the last year. Also, you are aware with this recommendation, the distinctive feature of this recommendation is that we first should do evaluation prior to the first course of the chemotherapy, evaluation prior to the first course of the chemotherapy. Seems in the main mode, in the same mode. So in the group of medium risk, we should consider the need of the chemotherapy individually, of course. And these recommendations also require evaluation prior to the second and other consecutive courses of chemotherapy based on the results which were achieved in previous treatment. So it's just to refresh and remind you, I think you know about that. What is next? It is next this summary of treatment guidelines in order to maximize the opportunity to deliver the optimal planned dose of chemotherapy while minimizing febrile neutropenia related dose reduction. The G-CSFs should be used in patients treated with established cytotoxic chemotherapy for malignancy to reduce the incidence of febrile neutropenia and the duration of neutropenia. So, and below you see that this recommendation require individual. I will not read it, you may do it for yourself. So it requires individual approach for the patients, as I mentioned, and individual assessment of previous results of this treatment. Well, so it is the guidelines, but what is the real world adherence for clinical guidelines for the treatment of febrile neutropenia? I said it was something new for me, but together with our colleagues from Chiva, we just checked some clinical trials. It's not my results. So, but survey of 213 German centers to evaluate the implementation of RTC guidelines. It's shown that adherence to and acceptance of guidelines for these drugs may not be sufficient. It is not our data, it is international cohort data. It's not be sufficient. Physicians may underestimate febrile neutropenia risk in patients who have an intermediate risk of febrile neutropenia, and they overestimate their adherence to the guidelines. So, seems we absolutely know clearly what should do in high risk and in low risk. But the great amount of this patient is with intermediate risk of this pathology. That's why we should be absolutely much more careful with this patient, because you see that in lung cancer, we have these figures, high risk, and these figures of intermediate risk. It's a huge amount of the patient with this risk, and the idea that we should be more careful in this patient, maybe a little bit complicated slide, but it showed the lack of adherence to G-CSFs prophylaxis, and it may increase the risk of the febrile neutropenia. You see that conclusion from this slide is that febrile neutropenia risk assessments was predominantly based on clinical judgment and individual risk factors. Guidelines for the patient at high febrile neutropenia risk were not consistently followed. That's a very important conclusion, I believe so, and these authors of this publication believe the same. And what we have based on evidence-based medicine principles just now in supporting this idea in lung cancer, in our pathology, which we are just now discussed. I'm sorry. Meta-analysis of 20 studies, 3 of which were, yes, I'm sorry, it's something unusual to speak with this device. You see, it's first experience for me. Next time I will not do it. Okay, I'm sorry. Primary prophylaxis is significantly reduced incidence of febrile neutropenia, especially in small lung cancer patients. So you see the statistical figures, you see, and I will go off that. G-CSFs prophylaxis significantly reduced neutropenia depth and duration. We have these aims and we have these results. It is evidence-based medicine, once again, principles and results which were proved. And incidence of febrile neutropenia during chemotherapy patient with small cell lung cancer is reflected over here. So why we just once again returning for this pathology? Because we shown that the figures are rather high for this pathology. And the primary G-CSFs prophylaxis reduce also the mortality. So you see the depth of events, the number of delayed cycles, the percent of maybe lack of chemotherapy due we not following the regimen of treatment, and primary, it reduced the mortality. So you see that these results were based on systematic review and meta-analysis of many trials with chemotherapy regimens, and relative risk of mortality was shown for the lung cancer, decreased. It means that in this pathology we have chances to receive success when we will using this tactic of treatment, and we will strictly following the guidelines which we just mentioned. Okay, so G-CSF and support delivery increased dose and intensity of treatment. I just mentioned these figures previously, but I just once again, together with these authors, I would once stress and repeat that it is really so, that the mode of chemotherapy treatment, when we receive this supporting treatment with G-CSFs, will be more reliable, let's say so. Well, I just switch on this slide because to make a little short conclusion for this topic, the prevention of febrile neutropenia is an essential component of care for the patient with lung cancer. And a rationale for the febrile neutropenia prevention is decreasing of FN-related mortality, especially early mortality. Yes, once again, especially early mortality. Minimizing the risk of delaying, reducing, or discontinuing chemotherapy. And we are approaching for time for our final conclusions, and I will read it because it seems, I believe, important. Lung cancer is the most common cause of cancer death in Europe. I think not only in Europe, but in the worldwide. The guidelines recommended combination chemotherapy regimens, many of which cause severe neutropenia. Platinum-based regimen, taxane-based treatment, topotecan-containing regimens may have associated with high risk of febrile neutropenia. Chemotherapy-induced neutropenia results in dose delay, dose reduction, and longer duration of hospitalization and increased risk of early and overall mortality. Patient and disease characteristics like cancer type, age, comorbidities, baseline blood cell count affect risk of febrile neutropenia. Prophylactic use of G-CSFs and antibiotics in high-risk population is associated with reduction in morbidity, mortality, and cost of treatment. However, adherence to G-CSFs guidelines is low, with high level of underuse and misuse. There is a need to continue education around the recommendation for G-CSFs support in identified high-risk populations. Long-active substances have been shown to be safe and effective in preventing of febrile neutropenia. Long-active G-CSFs may improve patient quality of life and chemotherapy adherence. Lipograstim significantly reduced the incidence of hospitalization in febrile neutropenia. Exploratory sub-analysis revealed a significant reduction in febrile neutropenia incidence with lipograstim versus placebo in non-small cell lung cancer in patients more than 65 years of age, and similar rates of febrile neutropenia between treatments and younger patients. So it was the final slide of this presentation, and I just will ask to switch on the second part shortly. But now, when it is going on, I'd like to pay your attention for what I missed in my presentation. So long-term and short G-CSFs substances. So it is also based on evidence-based medicine principles. It was proven that now the long-term G-CSFs may be more effective in comparison with the long one. That's why our trial, where we used such approaches, became really much more and more important. And I believe that now, thank you so much, we are ready to transfer to the second part of the presentation. So when we discuss with Teva, the specialist, the mode of my presentation, so I asked them for one small thing. You know that we are discussing, I had participated before in maybe 100 meetings because we performed many trials within the last 15 years. So I faced with such a situation. At numerous meetings where we participated in, we discussed the question, we are discussing the question related to those information which really we should know to perform this particular trial. But in reality, in real life, we face with the situation with sometimes dozens of trials, maybe not dozens, but many trials are simultaneously performed on site. And success of the trial or lack of the trial will be often depend not only of our perfect awareness in performance of special trial, one trial, but we should be aware in the principles of site management. We should honestly answer the question, are we know how to improve our activity and how to reach high goals? Because now, for example, for the lung cancer in Ukraine, which is not absolutely overloaded in clinical trials in general. So I just returned here from London, where I spoke with my colleagues from UK. They said we are absolutely overloading dozens of trials, and we are not able to show very high results in separate trials because we're really overloaded. That's why the question which I asked maybe to take a few minutes to discuss with you was, so how make the clinical trial site effective in during the clinical trials? Is it possible? Because we are professionals in medical, in medicine. We are not professional mainly in administrative questions. We are not professionals in the management questions and so on. Maybe it is the explanation why sometimes the trials are not so successful and it is difficult to reach our goals in trials. That's why the second part of my presentation I specially designed and prepared was the clinical trials. Future technologies. Today it is the slogan of our site, future technologies today, and to look for clinical trials, not only like trials, but like science, like technology, like an art. So maybe finally, but short presentation of my site, where we are from Ukraine, from this city with long name, Dnipropetrovsk. Foreigners often difficult to pronounce, say why it is so long. So I don't know, it was historically, maybe many people know that team from our city with Spring was was the finalist of European League game playing with Sevilla. Maybe the football made the city more aware about where we are, what are we doing. So, but we work in this medical academy which will celebrate 100th anniversary next year, and it is also important for us. So it is also who we are, and I represent the Department of Medical Oncology and the head of Chair of Oncology of Medical University. But we work together with university, hospital, university clinic, where this number of patients are treated, operated on, the medical staff, the staff of physicians, and the number of departments. I mean, it is maybe explanation why we sometimes may be successful in trials, because we have access to a huge area of the patient. And just now, few thoughts, few ideas about the principles of effective management. It is our point of view. We do not think that it is maybe guidelines or requirements for anybody. You much better know what you should do over there. My idea is only that we also should think when we perform the trials about effective management. It is important. So you see over here is the number of partners, the sponsors, the CRO, the companies with whom we are cooperated on, and it is nice for me to show this, and seems this. Yes, yes. So really one of our partners, I'd like to say I tested my system yesterday, and we performed with you some trials with 71 patients enrolled historically. We had experience of FDA audit successfully, and it is not forgetting. It is, of course, the question is really very important. So the results of this site during this year, we worked in 14 years with the number of trials which was done, with the number of patients enrolled, randomization level per 1 year, this number of informed consent, and over here the total number of trials which are performed on site simultaneously. I mean, they perform by means of one team and one rule. So maybe it is the explanation one we sometimes try to read something, because we have the same principles for all the trials. So, and all this stuff which was created within these years, just now we have this number of staff members, and the site is separated. It's my recommendation for everyone, because at least these positions are necessary and required to have success in clinical trials, because it's necessary to create teams, it's necessary to create cooperation between the colleagues, and maybe like the reason for success. We believe that present modern clinical trials staff should have its own infrastructure. Not my invention, but it may be a reflection of our site. You see Department of Chemotherapy, computerized tomography, pharmacy, technical group, and what is important, the development group. The group who create, we just now moving, it is maybe, description of our pharmaceutical department with some invention to ensure the safety, safe storage of study drugs. I paid attention of everyone. We should be absolutely careful with drugs, substances. We should ensure condition when our sponsors are absolutely aware and sure and believe that everything will be okay with their drugs on site. And that's why the special approach, a special modern system, I saw it in many hospitals and in many countries. That's why I will not comment, only to show how it looks like in our site. So, very important things to reach success in interaction with the patient. So, the patient should trust for the site and should really collaborate with the site, and we should implement some principles, I believe. For example, from our side, it is computerized system of everything what happened on site should be, I believe, computerized. It 3-4 times increase efficacy of work, efficacy of our labor, and it permits to perform simultaneously many trials. So it was designed for patient convenience of the patient. Very important, but when you have a lot of trials, you should create conditions when the patient will be not waiting too long for any procedures. When you separate the patient, for example, for 3 floors, in our site it looks like, for example, at 7:30 the patient coming to site who will receive today the chemotherapy. Most of them are treated in outpatient mode. That's why 7:30 the 20 patients, say, or maybe 30 patients coming to laboratory and collect collect blood samples, they will receive chemotherapy today. At 10 o'clock, another patient coming who will collect lab samples and receive all the tablets, for example, or they will not so long on site. And finally, at 8:30, coming the patients, only those who have need to talk with physician to check their general condition and so on. So it creates good atmosphere, and it creates maybe a flexible atmosphere, but comfortable for the patients. So I just want to show you something new, what we just invented for that. Well, we believe that some new things may positively influence for the results of trials. It is, as I said, site management. It is creation of specialized software and specialized computerized program which may really support the site during activity in the process of clinical trials. We just invented and implement the system of investigator computerized system which really make it possible for us to be aware in everything what happened on site. I immediately can see the results of all patients moving via the site from here may come to the website and see how it is in Dnipropetrovsk, long name Dnipropetrovsk. So it helps us to be effective. Maybe the discussionable question I just generated for the first time for this auditory because this video support of the trials we decided half year ago create first the website and after that create the YouTube channel where we, of course, following the confidentiality principles, we publish video materials from everything what happened on site. So this half-year activity had shown that when the patient may look to this work of the site inside, they are much more better aware about the site. They really have much more desire to be participating in clinical trials. So this question is for the discussion. So it's look like the first pictures of our website, Site TV. Look like you may came to the YouTube at Site TV and you see how it works. It is in English, it is in Russian language as well. Dear colleagues, thank you so much once again for your time and for your attention. It was a great pleasure for me to deliver this report for you, and I want to wish once again success for this new and very important trial which we just started. Thank you once again. Thank you so much.